الرابعة كنا اتغذيتوا بقى كويس. Avoiding dysfunction in children and update.
Thank you, Mr. President. First, I would like to thank the Egyptian and the American Urological Association for inviting me into this very successful course. And I know you had a very big dose of information in pediatric urology. And from the effect of the big dose, the projector exploded. So I will try to be as fast and as simple as possible. Unfortunately, the topic is a little bit tough, and it's at the end of the pediatric course, so I will try to simplify it as much as possible. First of all, in dealing with avoiding dysfunction, you should first bear in mind that we are talking about non-organic urologic or neurologic problems. So most of the time, these are anatomically sound children. They have a normal urinary tract and they have a normal neurologic innervation to the lower urinary tract. Remember, because this is the backbone, and you have with experience and a lot of cases that you can exclude the cases of urologic or neurologic anomalies. First of all, I will spend a couple of minutes giving you a reminder of how the lower urinary tract works, because abnormality in these mechanisms will lead to the voiding dysfunction. First of all, you should bear in mind that the urinary tract and the bowel are intimate. They have a very near embryologic pathway. So bear in mind that problems that happens for the lower urinary tracts is usually associated with problems in the lower GIT and the constipation is a hallmark of the phenomenon. So you should bear in mind that you should exclude the presence of bowel problems in these kids. And the proper term from the pathophysiologic point of view is the elimination dysfunction syndrome, and the new term now, which is the BBD, or the bowel bladder dysfunctions. And the normal function of the lower urinary tract, you should have two big aims, storage and emptying. But you have certain characteristics for each. You have to have a storage of adequate volume of urine at a low pressure without leakage. And at the time of voiding, you have to have a voluntary, efficient, complete voiding under a low pressure. So this is hallmarks of how the normal voiding pattern happens. And we think about the lower urinary tract as a single unit, and this is very important. And actually, not only the lower urinary tract, you should think of the whole pelvic floor. And the whole lower urinary tract is a single unit comprised of the uretrovesical junction, the bladder, the sphincter, the urethra, in addition to the normal urologic and neurologic innervation of this area. So bear in mind that this is function as a single unit, an integrated unit. This is very important. I will pass rapidly. You have a CNS control, and this happens with time, but remember that you have here the spinal micturition centers, which are sympathetic or parasympathetic or somatic. Sympathetic comes from the hypogastric nerve L1, T1, T10 to L1, and the S234, you have the parasympathetic and the somatic innervation, parasympathetic through the pelvic nerves and the somatic through the pudendal nerves. So remember this. And of course, knowing the molecular pathway is very important on how this functions. And the receptor issue in this area is important, and I think most of you now, all of you know the alpha blockers and the types of alpha blocker and blah blah blah, but you need to know how many receptors are present in the lower urinary tract. Here, the area of alpha blockade, the alpha receptors here are abundant. Here you have beta receptors and the nicotinic receptors mainly in the somatic pelvic floor muscles. So remember the receptors because it has an implication for the treatment. Remember that voiding, in order to have storage, first you have sympathetic alpha adrenergic activation, which leads to bladder relaxation, and you have the bladder can accommodate a large amount of urine in a low pressure. And at the same time, you have an outlet obstruction from the bladder neck and the external sphincter. And during voiding, we have the reverse. Voiding starts with the relaxation of the bladder neck. Then this is very important, where you have the outlet relaxation first and then followed by the detrusor contraction, which leads to the initial voiding. So as the child grows, you have evolution of the normal bladder function. And this is the area actually where you have the acquired voiding dysfunction issues. First, the bladder capacity increases with age, and it demonstrates increasing capacity. For example, in a child less than a year, the bladder capacity is about, you have this equation, the weight in kilograms multiplied by 7. In more than 1 year, this is important, you have the age in years plus 2 multiplied by 30. So you have to have an idea about the normal bladder capacity for the age. This is number one. And then the bladder should have sense of distension and accommodate increasing volume of urine without changing in the pressure. Again, you have to initiate voiding and sustain the contraction, and you void till completion. First, the bladder capacity increases with time, resulting in voiding that could happen each hour in the first month of life. And this is normal, up to 20 voids per day. And when the child grows older, at 3-8 years of age, the number of voids, normal voids per day, almost about 8 voids per day. And when they are reaching adolescence, they reach to the adult number of voiding, which ranges between 4 to 6 motions voiding per day. And another thing that we are starting to utilize very frequently recently is doing urodynamics in children, and this is very important. And you have few tips and tricks in doing urodynamics in this young age. First, the boys, you have in less than a year, in infant, the bladder pressures are very high, and this is normal. This is during the phase of bladder maturation. So the high voiding pressure is the norm at this age. Staccato voiding at the first year of life is also considered as a phenomenon which is not abnormal, because you have a transient phase of detrusor sphincter dysynergy. And during the urodynamic itself, you have to have a slow fill, less than 10% of the predicted bladder capacity per minute. You need to equate the bladder volume first for the age, and then you should have a slow fill less than 10%, and should have the fluid should be in the body temperature. And remember that the catheter size might affect your readings. We have the work of Maguire, and all of us know this curve, which is the lead point pressure more than 40 centimeters. We consider this is a hostile bladder. And the number 40 came from his work, from a Maguire work, where he found that the bladders in this category here, they do not have VOR or they do not have hydronephrosis. But when you have pressures high up in these dangerous zones, almost 86% develop VOR and more than 80% have hydronephrosis. So remember the number 40 while doing urodynamics. And you have a certain pathway, you have a certain arrangement for acquiring control. First of all, children get a nocturnal bowel control. This is the first thing that happens. This is followed by the diurnal bowel control, and then followed by the urinal control of voiding, and the last thing that can be attained, which is the nocturnal control of voiding. This is the last to appear. And remember, during the potty trainings, the girls will train much more easily and quickly than the boys. And this is the character of voiding that we don't like. You need to have a detrusor voiding while the outlet is completely relaxed. But the hostile scenario here is that you have bladder or detrusor contraction against a contracted outlet. And this is where you have high pressures and a lot of vicious circle of the events that could happen. We heard a lot with the talk of Dr. Isa about congenital anomalies that can lead to anatomical incontinence, and this is not our domain in the lecture, but remember that always there is a wet GERD in addition to a normal voiding, and you should suspect ectopic ureter in here. And according to the International Children Incontinence Society, this is an organic phenomenon, which you have a continuous incontinence, while the intermittent incontinence is mainly functional, and this is what we are talking today about, the voiding dysfunction, whether a daytime or nocturnal. If you have only nocturnal incontinence, this is nocturnal enuresis, and if you have, in addition, a daytime incontinence, so this is a fully symptomatic nocturnal enuresis. We have certain standardization for the descriptive terms for the detrusor muscle and the urethra according to the ICCS. So for the detrusor, we have a normal detrusor or an overactive detrusor or a hyperreflexic when you have a neurologic etiology like the myelomeningeal dysplasia. But if you have a non-neurologic etiology, you have the term of bladder overactivity. And for the urethra, either a normal urethral function or an incompetent urethra that happens like stress or giggle incontinence. During the voiding phase, you have certain descriptive terms, whether a normal detrusor, underactive, or acontractile, and for the urethra, during voiding, you have either normal, overactive, or dysfunctional voiding when you have voiding against a closed outlet. The disorders that we see during the voiding dysfunction that we described, you have almost 80% of the syndromes concerning the monosymptomatic nocturnal enuresis. Look how much this comprises the peak or the majority of the problems that we deal with. And 20% we have daytime urinary incontinence. And the prevalence of these will decrease with age. And if you have 4 to 6 years old child, you have from 10 to 20% incidence. And while the child goes older, the incidence drop to 4 to 5%. The risk factors, we have mainly a female gender, it's much more common in female, history of nocturnal enuresis, urinary tract infection, and stool problems. I will pass for every one of these rapidly, which is the main talk today, which is the daytime incontinence or the voiding dysfunction, which is the overactive bladder. The hallmark of this syndrome, like the adults, but now we see it in a more frequent scenarios in children. It's a sudden, unexpected need to void, and urgency is the hallmark. It's like the definition in other population. And we cannot say that this child is having an overactive bladder before he could attain bladder control. So this is very important. We cannot say that this child is having overactive bladder unless he is past the age of 5 years. And this syndrome we start to see it a lot in our children, which is the voiding postponement and underactive bladder. If you have this syndrome, the child will have an overstretched detrusor, which will lead to a weak contraction, underactive bladder, and lazy bladder syndrome. And the feature of it is holding maneuver, valsalva, and the large post-voiding residual urine and urinary tract infection. And it's in its most severe scenarios, you have an overflow incontinence. So we think of the functional problems that we have in these kids mainly towards primary measures regarding the changing a lot of information. You need parents who are compliant that helps you in giving you the primary measures, and they need to have to understand what's going on in their child. First of all, you have to change the voiding behavior modification, and this is very important. Actually, the idea of timed voiding in children is very beneficial. And if you have parents that are complying with this, and if you spend some time counseling them, how is the mechanism is performed, and how many times you need their kids to pee, is very important. And we see a lot of children that improved only in doing the primary measures. But problem is that we don't spend much time counseling. We don't have the specialized nurse that will do this for us, so it's a little bit time consuming. And I needed them all here because treatment of constipation as a primary measure is very, very efficient in treating the early phases of avoiding problems. So the primary measure is very, very inexpensive, but it means sometimes it needs counseling, and if you have a specialized nurse, it would be a plus. The secondary measures, we think of the medication. So our philosophy now is not starting with medication. Medications are not magic. You have to spend some time doing the primary measures, and then afterwards add drugs. Not to start with drugs and say that this will solve everything. No. You have to do the primary measures efficiently and then add the secondary measures. If you have an overactivity, give anticholinergics. If you have underactive bladder, you think of time voiding, frequent voiding, and CIC. And if you have dysfunction voiding or primary bladder dysfunction, you can think of biofeedback. Some of the examples that we see, which is the vaginal voiding, it is not uncommon. We see it and in the scenario, in the history, and if you hear the description of the voiding pattern of this girl, you will know that she's dribbling after she micturates for a very small period of time. They may have labial adhesion, and this is during VCUG, you see that urine flows out, and then some of them is retained in the vagina. And the treatment is simple. Just you need the girl to be fully relaxed at the time of voiding. And sometimes, and this is one of the tricks that I have learned so many years from Professor Mohlis, is that let the girl sit back while doing the micturition. And that's how the pelvic floor and the legs are completely separated, and she voids under complete widening of the bladder outlet and the introitus. This is a little bit uncommon situation. I haven't seen much of it, which is the giggle incontinence. And the problem here is that it's mostly in girls. When they laugh, they void almost most of their bladder capacity. It's not only a few drops. They just empty the bladder completely, and this is very social. On the social level, this is a little bit very embarrassing. And I don't have much information about the pathophysiology or how to treat it, but they have tried a drug which called Ritalin and alpha-adrenergic agents and anti-epileptic medication. I would like to give you another hint that this syndrome is common in practice, and we see it a lot, which is the daytime frequency syndrome, and it's present. And if you have some time to get a proper history, you can save your child a lot of investigation, and you solve his problem in a second. This syndrome is usually happening in males who are a little bit older, like 5 to 8 years, and they have a sudden onset of a problem, of a voiding problem. They were completely normal, and on the second day they have the problem. But they never lose urine, they never incontinence. And usually, one of the hallmarks here is that when you ask the mother, she tells you that her child is having frequency of urine during the daytime, but when he sleeps well. He can sleep for 6 hours straight without having any problem in going to the bathroom. Usually it's a self-limited situation, and the actual mechanism or pathophysiology of it is not understood, but it's a very benign phenomenon, and it's a self-limited, it needs only reassurance. Few slides about the constipation. This is very important. And one of the old studies that showed that constipation and the relation of the constipation to the lower urinary tract, and big number of children having constipation, they found that they have daytime incontinence almost 1/3, nighttime incontinence almost 35%, urinary tract infection more in 11%, and VOR in 16%. And only by treating constipation, just by treating constipation only, you have improvement in all these problems. The constipation, when relieved in almost half of them, the daytime